Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Hi, my name is Michelle Lynn with Dawson, and these are my financial disclosures. I am the author of Chasing the Swallow, Truth, Science, Hope for Pediatric Feeding and Swallowing Disorders, for which I receive royalties from the sale of. I receive compensation from speechtherapypd.com for CEUs associated with the book, for this podcast, First Bite, as well as for numerous other presentations. I receive compensation from PESI for one course that I have with them. I receive an annual salary from Wolf Speech Therapy Plus LLC, as well as in my capacity as adjunct professor at North Carolina Central University. And I receive profits from the sales of First Bite Boutique sweatshirts and t-shirts that Erin and I design. My non-financial disclosures. I am topic chair for the Pediatric Feeding and Swallowing Disorders for ASHA for the 2024-2023 convention. I am the chair of the special interest group, or co-chair of the special interest group for pediatric feeding disorders and dysphagia for the Speech Language Hearing Association of Virginia. I am a convention committee member for the Speech Language Hearing Association of Virginia. I am a member of the Speech Language Hearing Association of Virginia. I'm a board of trustee member with the Communication Disorder Foundation of Virginia. I'm a former treasurer with the Council of State Association Presidents, past president of the South Carolina Speech Language Hearing Association. I am a member of ASHA, ASHA SIG 10, ASHA SIG 13, SCISHA, Dysphagia Research Society, National Foundation of Swallowing Disorders, and the National Black Association of Speech, Language, and Hearing.
Okay. My name's Erin Forward, and here are my disclosures. Financial disclosures. I receive a salary from Cincinnati Children's Hospital Medical Center. I am the owner of Forward Education LLC, where I do courses. I receive royalties from Speech Therapy PD for this podcast, First Bite, and other presentations as well. I am also a owner of First Bite Boutique with Michelle Dawson and receive compensation for that. Non-financial disclosures. I am a contributor for the book Chasing the Swallow by Michelle Dawson. I am a member of the South Carolina Coalition for DIR Floortime. I am a member of ASHA and SIG 13, as well as Dysphagia Outreach Project and Feeding Matters. And I think that's it. The views and opinions expressed in today's podcast do not reflect the organizations associated with the speakers and are their views and opinions solely.
Happy learning. Hi, folks, and welcome to First Bite, Fed, Fun, and Functional, a speech therapy podcast sponsored by SpeechTherapyPD.com. I am your host on this nerd venture, Michelle Dawson, MS CCC-SLP CLC, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention right there with you. I run my own private practice, Heartwood Speech Therapy, here in Coletown, South Carolina, and I guest lecture nationwide on best practices for early intervention for the medically complex and fragile child. First Bite's mission is short and sweet, to bring light, hope, knowledge, and joy to the pediatric clinician, parent, or advocate.
By way of a nerdy conversation, so there's plenty of laughter too.
In this podcast, we cover everything from AAC to breastfeeding,
ethics on how to run a private practice,
pediatric dysphagia to clinical supervision,
and all other topics in the world of pediatric speech pathology. Our goal is to bring evidence-based practice straight to you by interviewing subject matter experts.
To break down the communication barriers so that we can access the knowledge of their fields.
Or, as a close friend says, to build the bridge.
By bringing other professionals and experts in our field together, we hope to spark advocacy, joy, and passion for continuing to grow and advance care for our little ones.
Every fourth episode, I join in. I'm Erin Forward, MSP, CCC-SLP, the Yankee by way of Rochester, New York transplant who actually inspired this journey. I bring a different perspective, that of a newish clinician with experience in early intervention, pediatric acute care, and nonprofit pediatric outpatient settings.
So sit back, relax, and watch out for all our squirrels and enjoy this geeky gig brought to you by SpeechTherapyPD.com. Y'all, we have none other than the Rachel, I'm not going to get this right, Archambault.
You use
Oh, bloody hell. I practiced that so much in my head. And I choked right out the gate. But Miss Rachel is going to, one, give me grace, and then two, thank you very much for the grace. And I wholeheartedly apologize. But she is none other than the PTSD-SLP. And this has been a labor of love, if I could go out on a limb, and comes from a place of heart healing. And then every once in a while in your lifetime, you will meet an individual who has had a bad hurt and a deep wound. And yet somehow they find the tenacity and strength to not only pull themselves up by their proverbial bootstraps, but then turn around and help others in their time of need. And y'all, she is the living embodiment of that, and kind, especially when you run into her like on an elevator and she doesn't know you from Adam and she's still like, hi. So Rachel, thank you so much for coming on. And we have our Erin, OG Erin. Yay.
Thank you for having me. That introduction was just like so sweet. And I do think of you when I think of my start into presenting and everything because of how long ago we met, probably at one of the first Flasha I presented at, and the encouragement that I got from you all. It was such a, you need to keep doing this. You need to share this. And the encouragement is what propelled me into this. So thank you for that, because you were one of the people I can think of immediately that were one of the reasons that I do this.
Yeah. Now you're going to make me cry. But yeah, this is what we do. You see a light in somebody and then you shine it because our world needs that. So, all right. I'm going to be honest. Today's topic is something that, and there are tiny ears in the other room, but I have unfortunately had my fair share of one type of trauma. I know that you've had yours, and Erin, honey, I know you've had yours. And trauma is not a conversation to be entered into lightly. So everybody, I don't have enough warning signs to plaster for today, but we'll probably cover anything and everything in between that could impact you as a human. So please know, here's your warning sign. Guard your heart and know that this conversation will be from a place of love. Erin and I have had a lot of conversations about trauma and what it means to be a trauma-informed clinician. And honestly, she was my first mentor in truly what it meant to be a trauma-informed clinician, because you took, what was the class that you took all those summers ago,
TBRI.
Erin? That was, yes. But I have not had this class or that formal training. So I've had to do on the job. So you two, in my mind, are subject matter experts on this. And I am a humble novice and survivor. So there's that. So I will pass the baton off. Erin, I'll let you get us started because I feel like you're really good at setting the stage for this
Well, and why don't we also, we know Rachel. We assume a lot of people know Rachel.
Oh my God, yes.
If someone's listening and for some chance they haven't known of Rachel, we'll let you tell your story and then we'll go into branching off of that.
Sure. So I'm Rachel, also known as PTSD-SLP on Instagram. And my passion now is talking about trauma-informed care. And that would not have been my progression without experiencing specifically a traumatic event at work as an SLP. For those of you who don't know me, I worked at a school in Parkland, Florida called Marjorie Stoneman Douglas High School. And I was a second year SLP, just a little baby SLP in 2018 when a traumatic event happened at the school. 17 people died, 3 adults and 14 children. And through that experience, when we came back after, which was a week and a half after, the students came back 2 weeks after, I didn't know how to care about speech anymore. I did not care about speech anymore. And my concern was, how do I allow these students and myself to feel safe again? What do I need to do to work with these students and myself who had gone through trauma and continue to go through trauma? And I went on Google and I found something, a concept, a mindset called trauma-informed care. And I realized that some of the things I was already doing, but it needed to be done at a higher level, especially because then it turns into trauma-specific or trauma-sensitive concerns. So there's kind of different areas to go into, especially because my school, we have a known trauma that everyone experienced, or possibly everyone experienced. Trauma-informed care was what led me to go back and consider all of my areas, not just in a school. I worked in a private practice. I worked in acute care. I worked in skilled nursing. I worked in all of the areas that a speech pathologist can work. And I started reflecting on certain memories I had of, here's how I would have made this more trauma informed, or here's how you can make this more trauma informed. So my experience that day and those following years has led me to make my practice as a speech pathologist as trauma informed as possible, and then to be trauma sensitive in certain cases, but mostly trauma informed. I view trauma informed as like a preventative measure. And then anything beyond that is when you know a specific trauma has happened. So that's a little bit about myself, but it has all come from a place that I never meant to go into this section, right? I never meant to find trauma informed care, but it wasn't until I needed it that I realized all SLPs should be using trauma informed care.
My immediate thought, wearing the hats that I've worn professionally, is how are we teaching this academically? Because I can tell you, being well by a lot of years the oldest lady in the room, this was not on the radar when I was in grad school. And having worked at a couple universities, it is just entering conversations. But as it's not part of the ASHA Big Nine, which y'all, there is ASHA's Big Nine, and having to teach the Big Nine and some of them across the life continuum is quite taxing and time consuming. What programs have to adhere to for Council of Academic Accreditation. So please know I'm not belittling what professors have to do. They got to cover a lot. But there's some programs, like Erin, you had a counseling class that was optional. And that's optional within some programs, which is a great starting point. But then I think, shouldn't this be embedded within every single topic? Because even down to artic and phonology, you can have a child that has an articulation phonological impairment because of a craniofacial issue, but then they've endured potentially the trauma of having to go through surgeries or having, X, Y, and Z done to their face without fully understanding. And so what I'm saying is, if you are in a capacity with which you teach adjunct or with which you teach a class, please reassess how you're teaching that class so that we could say, how can we teach the future generations from a textbook, from that first fundamental building block, how to go about being trauma informed.
Absolutely. So, you completely, I agree with you completely. I'm happy to say I've had a lot of professors at undergrad level, at grad school level, reach out to me to present to their classes, or it's the students that found me on Instagram that are referring me to the professors or referring me to their student association and saying, can you speak to us? Which I'm glad someone is asking for it. But I think, yes, it should be done per class, because you could break it down per situation of, here's how we could be more trauma informed in this example. So you were talking about articulation, and I am someone who has been diagnosed with PTSD and ADHD. With both of those things, I do not like being touched. I'm not too much of a hugger, except at Flasha and Asha, and for you. I'm a big hugger for you. I don't like hugs or other stuff when it's not like my choice to do that. When it's my choice, which is one of the tenets of trauma informed care, I'm all about it. But I need to feel safe in that moment. And I think that's why I enjoy Asha and the state conferences, that it does feel safe for me there. But when we're talking about like touching, I think we have this expectation, especially in articulation or some other sort of therapy, that we just grab onto a kid's face, or especially for like prompt therapy or anything like that. We're just grabbing onto people. And for me, I think that would cause like a punch to the face if someone just grabbed my face, or like, and we have to consider, like, we don't know necessarily what our clients have gone through. I would always prefer to ask the question, is it okay if I touch your face? Or if it's not okay for me to touch your face, can I use your hand to touch your face? Can I show you what it looks like on my face? We're giving choices here, which is more trauma informed. So you should always be asking yourself, how can I give more choice to the client? If we're saying that this is something we need to do with touching their face, how can that be done in a safer way for them? Or does it need to be done at all? These are questions as a trauma informed provider we can ask ourselves, and not just with the kids, not just in the school setting, also medical, also with older people. We need to be doing this at all levels, all settings.
Yeah, and I think as a speech pathologist, we have this unique perspective as well, because we specialize in communication. So we have this training to understand these very subtle cues of safety or dysregulation. And if we take that hat and that lens, we can better understand when a child, adult, a person is giving us information about what they want and don't want, what choice they might make and not make. And we have to be more in tune with that, because those signs of safety and or not feeling safe can be so subtle and are so individualized. My pupils getting dilated, I'm sweating, I'm breathing heavy, my body language, all of these very subtle things. When we focus only on that big nine, we're missing a lot of that foundational, what makes you feel safe? How do you show someone you feel safe? How do you advocate for yourself? And trauma-informed care gave me that permission, not that I needed it, but that permission to have now a foundation to explain why I was doing what I was doing, why I was backing up, why I was building relationship.
Absolutely.
It is humbling to look back on one's career and to see how much change has happened and how much we have shifted as a profession. And please know we're not done. But from the SLP is the authoritative figure that you will do as I say, what I say, and how I say, that when you walk into the classroom or the therapy room, you're going to sit at the table and you will do this, this, and this, to now. And I feel like trauma informed immediately in the peds world can go towards and should go towards child led and positive affirmations. And I mean, I am first and foremost, I love Jesus and I cuss like a sailor. Those are some of my biases. But to me, it's what is that child's love language? Like, if I am engaging in this aspect, am I honoring their communicative intent and where they are? And their readiness will change day to day, session to session. So what they needed last week might not be what they need this week. And especially for our medically complex kids. Y'all, this is why I always go back to, are we doing the caregiver routines-based interview? Because also when we're working with pediatrics, we have to take into account where is their caregiver on this journey and what they're going through. Okay, so how do we start the conversation with how to learn about what is trauma and take away our individual biases from, well, that trauma doesn't seem as big as my trauma.
Definitely. So there is this theory in the trauma worlds that I hate, and it's big T and little t trauma, which basically assigns a value to, do we think it's bad enough? Which, talking about what I've gone through, most people, I would say 100% of people, 99% of people would say that's a big T. No one can question that. But then even within my community of people who were there and experienced it, they might say, no, yours is a little T compared to mine. So when we get to that game of, well, that doesn't count, or that does count, we're invalidating possible trauma. So it's important for us just to recognize that trauma is an individual's experience of something. And that being said, we do as a society use the word traumatized a bit too often, like, oh, I'm so traumatized, I broke a nail, which I think part of that came from the lessening of the stigma of mental health, which is a great thing, but it's also kind of made people fatigued of the word trauma, that they're like, oh, get over it, you know? So it's important for us, I would say, as a clinician in any setting, any level, just to assume the reality is my clients possibly have experienced a traumatic experience. How can I help? How can I prevent myself from harming them, re-traumatizing them, traumatizing them without knowing what their backgrounds are? And I think there's little things that we can do there. And of course, in some reports, we're going to have that history there. We're going to have certain things or some cases that we have. So I'm located in Florida. We're surrounded by water. We have a lot of near drowning accidents that happen here. And then they come into the school system. They are AAC users. They are paralyzed. And I think of the parents that have had to endure the medical trauma, the incident itself, and then everything that happens after that. And they come into an IEP meeting and they are aggressive. They are mean. And who I was in my first 2 years, I would have been like, oh, what's wrong with that parent? Why are they acting that way? And the trauma-informed mind shift has said, wow, look at all they've gone through to get here. Maybe they've been prevented from getting access at some point to something, an AAC device, a wheelchair, or whatever it is they need. Maybe the medical trauma. Maybe they are just ready to fight for their kid. And that mindset shift has made me a better clinician because I'm not taking things personally. They don't know me. They're not taking it out against me, but I understand that they are thinking that this is their way to get what their child needs. They are advocating for their child. Maybe it's not the best way that we might say, hey, how about you're a little nicer?
We might think that really loudly, though.
Yeah. I think it's up to us to have that mindset shift that we are meeting people where we're at. And then once we build that relationship, once we show them that we are trustworthy, then they can let their guards down and not act like that to us. Maybe they view us as a safe person and say, Rachel will advocate for me. Rachel will advocate for my child. So all of the tenets of trauma-informed care, which I'm sure we'll go over right next, doesn't need that definition of what is a traumatic event and what isn't. The example that I use all the time is divorce. If I were to ask all of the audience here what, on a scale from 1 to 10, what their experience, how bad it is, how traumatic it is, it would be all across the spectrum based on their own personal experiences. So if they're seeing a student whose parents are going through divorce, they might say, don't worry about it. It's not that bad. Everything will be okay. And some of those kids just need validation. Like, that does sound tough. So sorry that your family's going through that. Especially my favorite age group is high school. That's my favorite group. They just want to be heard. So it's important for us as the professionals. We're not providing trauma therapy. That's not our role. We're not deciding what is trauma for one person or another, but we are supporting our clients. We are advocating for our clients. We are getting them the supports and services that they need in order to access the curriculum, to access the spaces they need to get into. Whatever it is, that is our role.
Divorces. Yep. And I'm just thinking of what it does to a tiny human and then to the caregiver's ability to engage and participate in therapy. It rocks both ends. It's a house built on sand. Also, my next thought is, darling, how'd you do in the storms?
Totally okay. I'm in Fort Lauderdale, so we were east enough and south enough that it actually didn't affect us here. I woke up at 2 or 3 in the morning with some nasty winds, but that was it. My brother had to evacuate Tampa. He was at my mom's, and they're going back and seeing what the damage is, but everyone is safe. Everyone's okay. It's been a wild 3 weeks or so.
I'm
Yeah.
sure.
Well, I was
okay.
and I think too, it's thinking about, not comparing traumas, but also our world is so different and it's so fast paced and it's so hard to keep up, and people are getting bombarded with so much information. And so even just day to day, these little things that add up based on your differences in your sensory system and your, if you are neurodivergent, Michelle and I both also have ADHD and
Wow.
I have OCD sprinkled in there as well. So it's just the world is challenging, and Michelle and I work primarily with medically complex kids and autistic kids, and just going through their day can also be traumatic in regard to just it's hard for them to feel safe.
Yeah.
I always say too, like a kid, anytime a child comes into my therapy session, I view them as kind of having this, and a caregiver having this suit of armor that they've had to develop. And our job is to help them feel that they can take down that armor, but we don't get to decide when they do that and how they do that. And we have to be patient, and we have to, like you said, I love the don't take things personal. That was a huge shift of that caregiver, because you're right away, understandably so, you're going to have an immediate reaction of like, oh, I didn't love the way that felt towards me. But then when you take a step back and say, oh, again, they don't know me. This is not personal. This is how they're, expressing whatever they need to express. And coming from, as Michelle always says, seek to understand is a big piece of that. But I think then the question, like you led into, is how, and going through the pillars, I think is really helpful if we want to start there. So we're all on the same framework too, of like, what are these things I need to account for to be more trauma informed?
Sure.
So what are the pillars? And if folks are not driving, ladies and gents, or on a Stairmaster, that would be dangerous as well. But what resources can they look at while we're talking?
I think there's a lot of resources out there. I do like to recommend, if you're driving, a podcast would be great, or an audiobook. One of the books that I recommend is What Happened to You by Oprah and Dr. Bruce Perry. I think that is an incredible conversation. The audiobook is so well produced. As someone who has built a career off talking about traumatic things and her upbringing, and then the world's leading expert in child trauma, they're talking together about experiences and how to be more trauma informed and the mindset shift that you need. And the title of the book is What Happened to You, because we're taking that. Yes, that's it.
Yeah, that's great.
It's a great audiobook. We are taking the mindset from what's wrong with you to what happened to you. That's how they start off this book. And that really is the mindset shift. And the example that you were just giving, I remember I had a freshman come into my room the first day. I call her in, and she bursts open the door. It slams open, and she's like, I don't have speech anymore. Whatever. And then she like softens up a little bit, and she's like, who are you? Like, she looks at me. She's looking at my room that's got sparkly lights. I have the lights off. I've got like calming decorations. And she's like, well, I'm only on consultation now. And she ends up telling me her previous speech pathologist at the middle school level embarrassed her, made her feel like a baby. So she actually went off direct services to consultation because of the embarrassment, which is a trauma. So I understand, instead of saying, walk outside and try that again, I don't even know you, I'm not going to take that personally. I want to understand why she did that, right? So I'm meeting her where she's at. And I say, oh, I'm Miss A. I'm the speech pathologist. I just wanted to check in, make sure that you're starting off the year okay. She ended up in my room about 4 times a week, like, because she ended up seeing that maybe I can see this person as a safe person, rather than my previous experience with a speech pathologist did not feel safe. She had the choice to decide that on her own. So when we're going into pillars of trauma-informed care, how I usually get mine is the 6 pillars of trauma-informed care, which is from SAMHSA. They had a paper in 2014 that is groundbreaking and just kind of lists what a trauma-informed place should be. So these 6 pillars would be safety, choice, collaboration and mutuality, trust and transparency, empowerment, and then cultural, historical, and gender issues. So my top 3, I would say, of all these that I always have in mind are safety, choice, and trust and transparency. And I feel like they almost go into one, but they're separated for a reason. But safety is, for me, my top, because even though these don't have a progression or a step-by-step order, safety, if we think of like Maslow's hierarchy, is at the very bottom, right? We need to make sure people feel
Yes.
safe in order to be there. And in my specific situation at the school, our safety was broken. Our trust in the safety was broken. Our choice to be there essentially was broken. So all of these pillars we have to build back up. And if you're starting with a new client, of any age, we need to prioritize safety, choice, collaboration, mutuality, trust and transparency, empowerment, and cultural, historical, and gender issues. All of these things help us create relationships with our clients and ultimately will affect us being able to meet those goals that we've set for our clients. If these things are not met, it is going to be much harder for them to meet their goals, because if I just have that girl come in and sit down and say, we're working on your R's today, I've already started off like, hello, hi, who are you? Like, we have to put away that authoritarian mindset of I'm the person in charge and you are the student, you are the client of, you're 98 years old, but you're my client. We have to have choice and collaboration with them of any age. Doesn't matter if they're 3 years old, right? We can still collaborate with the 3-year-old. We can decide what we want to work on today. We've got in mind, oh, they're working on their R's today, but how are we going to do that? What would you like to do? And you as the SLP, think on your feet. Ooh, we can target her R's here. We can do this here. There's so many ways that we can do it, but the way that I would suggest you start with this is just having in mind these 6 pillars and asking yourself questions. How can I provide safety to this client? How can I make them feel safer in this room? You can even ask them. You can ask your client, what would make you feel safer here? I think that is a very basic question that they may never have been asked before. These are ways to start the safety of the room so that you can start working on other things. But that would be the number 1 priority.
And I think too, the fastest way to feel safe neurobiologically is through relationship. So like straight from your right frontal lobe to your amygdala is relationship. Taking the time to learn about this person, taking the time to figure out who they are, this child, this adult, whoever you're working with, is going to foster that safety, that foundation for their development, all these other areas. We develop skills and go through development within the context of relationship and affect and emotion and all of those things. I think it also helps us, again, take that step back and say, I need to take the time to learn about this child. I need to take the time to learn about this caregiver. That is therapy. That is valuable. That is important. And if this day we're not, targeting R's as much as I would want to, if I'm building a safe foundation, I'm setting them up for more success so that when they come back next time, they already are leaving with the understanding that this is a safe place and they're going to be more likely to hopefully come back and want to work with me. I say it about feeding therapy, and I work with a lot of non-speaking children. I want them to find a way to tell me no. If they cannot tell me no and I don't consistently know when they don't want to do something, I will not start feeding therapy. Because they need to feel choice, safety, trustworthiness. And that all is so collaborative. And I love our field. But to Michelle's point with the big 9, it's so deficits based that we feel like we have to target these very specific skills, but we don't give these kids a foundation to do so.
We don't give our younger clinicians a foundation to do so. younger clinicians in their clinical practicums, they are tossed in and expected to perform, which in and of itself is trauma inducing.
One of my favorite things that I've been speaking on recently is trauma-informed supervision, because it's the supervisors that are creating so much harm to the grad students, to the undergrad students. I just presented at Flash last summer in June, and I did, I think, 2 hours on it. And the response that I got from these seasoned SLPs came up to me and said, "Oh my gosh, I didn't consider all this. I know what I need to do now. I know how I can change this." I have several experiences with a supervisor that prevented me from being in the medical system because she wrecked my self-confidence. And it was a very confusing time because I just wanted to do medical. So we need to make sure that these pillars of trauma-informed care are not only for our client, but for the SLPs, for who we are bringing up in this profession. And they need to see that modeled so that they can do that to the people that they are supporting. We can only be as trauma-informed as the systems above us.
And you can change the system and you can break the system and you can rebuild it, but you have to have allies and partnerships with which to do so. And you can't, as much as I may have wanted to over various points in my career, burn it to the ground, it doesn't always, it's not as effective. So so have you heard of something called CAPS?
I don't think so.
CAPS is the Council of Academic Programs for Communication Sciences and Disorders. And they have, so folks, if you're listening, the behind the scenes stuff, CAA is essentially, they set the requirements for what must be taught in order for programs to obtain accreditation. Then there's offshoot associations that are kind of surround our profession, right? So we've got, each state has their own respective state association, only recognizes one state association per state. So like Georgia has GASHA, but they also have SSLP, right? But they're not the same, right? Like that's ASHA only recognizes GASHA. Then states align and they participate in something called CSAP, which is the Council of State Association Presidents. But CAPSID is the association for faculty, where they can get together and create brainstorming think tanks. How are we process improving? We have CAPSID coming on, immediate past president, Dr. Jennifer Simpson, who was last year's convention chair from ASHA, and a couple other CAPSID guests have been on, right, to expedite this. They're willing to grow and learn, but you need to get in with CAPSID and speak to them about trauma-informed clinical supervision so that it's on their radar. And I know you need to, because
it really is. I mean, something, I've worked in many toxic work environments, and just thinking of being an undergrad, a grad student, a CF, all of these supervision requirements that they're not technically my boss in a way, like it becomes a very toxic work environment. And just me now as a SLP working in a district that are a lot of things going on, I'm looking at all these decisions that are made above me that affect the people way below. And if they had considered a trauma-informed care mindset, they would reduce the harm that they are causing to the people that work for them. And we need to be doing that. So I've used all these like leadership style books because no one trained us to do supervision. Like we take a course, but they're not talking about how do we reduce harm. They're just talking about here's how you observe this kind of situation. But we're not taking it from a trauma-informed perspective, and we're causing harm. We're causing people to not choose this field or to get out of this field very early. So we need to do our best to not cause that harm and lift up our people to support them and not prevent them from being in this field.
Mm-hmm. You, ma'am, have given me food for fodder. Okay, also fun story. This equates to my Friday afternoon. I had a little guy come in and he'd had big emotions in a big day, and comes from a family of neurodivergence. And he was exhausted. He fell asleep on the car ride on the way over to feeding therapy. Dad was like, I don't know if he's going to be able to wake up to participate. And I'm like, that's okay. Caregiver coaching, we can touch base on how the different foods have gone. This kid is brilliant. I'm not unconvinced he doesn't have selective mutism because he doesn't like to speak to me. But when I walk out of the room, he'll speak and whisper to his mom. So mom set him down in our lap, and I could see that he wasn't really asleep. He was, we were pretending to snooze. So mom put him down on the ground because he likes to sometimes sit on the ground. And I was like, you know what, Bubby? I was like, it's okay. You rest your soul. You rest your heart. Shell's just going to talk to the mom. And they brought in mandarin oranges because mom was real big on it's getting gray and we need to have vitamin C in our body. So I just sit there and I'm peeling and I'm talking with mom, finding out how he's done. All of a sudden, I kid you not, a little bitty finger popped up. and then like a hand came up, and it was a hook because I was talking about how I hooked my finger to pull up. And so I put the orange under and he starts peeling it back. And then it was this little eye, but it was just this slow. And then by the end, he put the orange in and made it like a big smiley face, like a jack-o'-lantern, because, y'all, we are recording in October. And then we made an aluminum foil bowl of all of our orange slices, and he had fun making it and then put his orange slices and walked out the door. But he was excited and curious, and there was no pressure because I know at the end of the week, he's had a big week and a big day. And I wouldn't want to go do therapy on a Friday. I wouldn't have anything left to pour from. And I think that analogy of like, what does that human's cup look like and what can we pour into it holds merit there.
But you're also in an environment where that is supported. You're in an environment where if you end your session after 15 minutes because that child is not having it, that's okay.
Yes.
I acknowledge and recognize and empathize with people who are in an environment where productivity is shoved down our throats. And so you feel bad. You're feeling this pressure to keep something going, even if it's not what's best for the client or the patient at the time.
Productivity.
Yeah. And it's really challenging to do. And I always tell people, and maybe I'm wrong about this, when people ask me sometimes of like, when do you know to discharge a patient, or how do you feel comfortable making these decisions? And sometimes my answer is like, when my gut tells me something, like you can feel when something doesn't feel right. I at least think most of us can. We go into this helping field, and that's when I start to ask questions. And that's when I start to say, is what I'm doing ethical? Is what I'm doing supporting this client's safety? Is what I'm doing? But that's, to your point, Rachel, like that starts up top.
Right. So when we're talking about productivity, it's an arbitrary number, right? Who sets that number?
It is.
So when we're talking about the systems in place above us, we're talking about productivity. So what makes someone choose a 90% productivity versus a 75%, right?
Somebody's bottom line somewhere down the line, and they're probably in accounting and not in clinical.
So I've heard of great practices that have bumped it down because they understand that patient relationships are the priority. And that's what I look for in a trauma-informed practice is what are you setting your productivity standards are, which I know some are big corporations, they're companies that it's a little person saying, excuse me, can you bump down that productivity? Like that's a really tough thing to do, but we can advocate for it based on the research of trauma-informed care and saying that we are actually causing harm in this case. If we're putting people at 90-95% productivity, that's an impossible thing. And people are fudging numbers. People are doing what they're not supposed to be doing to get to that point. And there are many people who I can't tell you how many new SLPs I have, and even several not new SLPs who do not go to the bathroom the entire day.
That's terrible.
I'm telling you, and I'm sure you out there are maybe one of those people that do not eat lunch, that you feel uncomfortable going to the bathroom because you have to be on all the time. If you teachers and related professions have UTIs at a higher level because of this. So we are actually causing harm to our bodies. It's not okay to be doing that. So when we have these unrealistic expectations of productivity standards, that is a choice that is being made, and it is not a trauma-informed choice. If they were to ask the providers, what do you think is doable? Where can we meet in the middle here, maybe? What do you think? If someone says a 50% productivity, like they're going to be like, no, no, thank you. But when we have those standards, they're not thinking trauma informed. So that's what we have to have these companies, these organizations say, where are we actually causing harm here? And maybe take a step back there. And that would show, if I have a company that says, you know what, we are going to look into those productivity standards and see where we can adjust, even 5%, I'd be like, wow, thank you for taking that into consideration. But we're, again, looking at these pillars of trauma-informed care: safety, choice, collaboration, mutuality, trust and transparency, empowerment, cultural, historical, and gender issues. So for the productivity issue, empowerment, we want to empower our employees to make those decisions, and not just some guy off at home making these decisions of what productivity should be, no matter what level you're at. If you're an SLP at a school, if you're in a private practice, if you're a business owner, these are things that you should take into account, each of these pillars, and say, how can I make blank feel more safe? How can I make blank have choice?
So Sarah Emery, who's the vice president of recruiting with Cicero Therapies. I know Sarah from South Carolina. She owned,
Yes.
good Lord Almighty, MTS, thank you. MTS therapy for kids up in Greenville, South Carolina. She does a killer presentation. She's also, full disclosure, she sits on the LLR board in South Carolina, license, how you get your license, right? She does a killer presentation on how to interview and does free trainings on the interview process for companies. But this is part of that. When, regardless of where you are in your career, when you go in for the interview, these are the questions that you need to be asking of that prospective site, whether it be a school, a private practice, a hospital, whatever the setting is. Are you asking, how do they adhere to these pillars? How do they engage in trauma-informed care? Is this something that you want to be a part of?
I think
the scary.
Well, I think to Rachel's
it's
point,
scary.
It's being talked about. And being in the space, I think it's being talked about more than it is being talked about. And then you like go somewhere else, you're like, oh, whoa, we have so much work to do. Like, people don't even know what trauma-informed care is still. But in regard to patient care, client care, but I love opening this conversation about trauma-informed care, starting from the space and work and with your employees. Kim Barthel actually does she just started a course on really talking about like, how do we help each other feel safe in the workspace? Her trauma sensitive course is amazing. I'm obsessed with her. She's an OT. She's brilliant. Her understanding of neurobiology is like, I could listen to her talk all day. So she goes into a lot of that piece. I wanted to work in medical so badly. Like, I wanted to work in the NICU. I wanted to do pediatric medical because we are taught that is like the working at the top of our license.
One, go baby, go.
Okay. So I was saying that I wanted so badly to work in a pediatric hospital. There were so many red flags during my interview process, like so many red flags. Took me 9 months to get hired. It was back and forth. And I think my gut knew that this wasn't the right place, but I was like, this is what I'm supposed to be doing. And I only lasted 5 months. They would want me to work 12-hour days when I was only supposed to work 8. My notes were picked apart. Everything I did was told I was doing wrong. And I vividly remember walking into a patient's room at one point with the person that was training me. And it was a child that had a gunshot wound and all this traumatic experience. And they tried 45 minutes to feed this child an ice chip to see if they were safe for anything. And I stood there in utter shock and walked out. And the person training me looked at me and said, I'm confused as to why we were in there for so long. It was very obvious that he was having a hard time. And she was like, well, what would you have done differently? I said, I would have walked in and recognized that he was not ready for this right now, and I would have walked away. And she said, well, the doctors need us to give him something. I said, I would have told the doctors that that's not what I would have done. And after I stood up for myself, I was pushed to outpatient for a couple weeks because they did not like that I stood up for myself.
And I ended up quitting and leaving and saying that this was not a safe place for me. And I remember when I went into my next interview, I asked questions like, are you comfortable with change? Are you comfortable with different ideas? Are you things that are, I didn't have the language from a trauma-informed standpoint at that point, but I knew, and I do feel like there's so many younger clinicians that go in and are starved for what setting they think they want or where they want to be. And we push aside a lot of these values to be there, when in reality, there's so much more value to feeling safe and feeling comfortable and being in an environment that upholds those values so that we can do that for our patients. Because like you said, I was in an environment where I didn't feel like I could treat patients the way I wanted to treat them because of what was happening
I
above
think a
me.
lot of us have those experiences. I mean, just hearing you talk about that, I feel like I had almost an exact same experience in my setting. And I know when I go to all these conferences, I have students who come up to me and they tell me, I think I'm going to fail. Like, I don't think I'm going to pass my final semester. Like, what do I do? And I was put in that position that, you know, the communication, the collaboration part, the mutuality, the trust and transparency, that part was not discussed with me until midterms, that they're like, you know what? I don't think you're going to meet requirements. What do you mean? In my last semester, you're saying that I'm not going to graduate? Like, what does that mean? So the way that we can support our SLPs, we have to reflect with what we are saying. Like, why do we think that way? So from a supervision component, it comes down to all levels discussing how they can make the people below them feel more safe, have choice, have collaboration, which in your case was non-existent. They're saying, no collaboration, you're wrong, move on. Trust and transparency, empowerment, they're playing down your empowerment. You are too empowered, settle down. Cultural, historical, and gender issues. I can't tell you how many times I'm in South Florida. That is a multicultural melting pot. And a lot of trauma or harm comes from people who are not of the culture they are treating, making decisions based on what they think is appropriate. And we need to be very mindful of that. I think number one, besides going through each of the pillars, is understanding our dysregulation. That is one of the biggest things that I've been interested in the last couple years, because I see dysregulated adults and they are trying to regulate dysregulated clients and punishing them for not being regulated, which is impossible. If you are dysregulated, you cannot regulate someone else. So when I ask many of my SLPs or SLPs that I'm presenting to, do you know your stressors? They don't know what stresses them out. And I know for me, I can name them all. I know what my stressors are. And one of them is noises. And that's from ADHD and that's from PTSD. I have such a difficult time concentrating with noise. So when I'm in a room and I hear a lawnmower going for 4 hours outside my room, I'm going to be tense. I'm not going to be as bubbly as I try to be, which I'm not normally a bubbly person, which was also something I was reprimanded for in my private practice setting, that I was told I looked like I didn't want to be there. It was also 7:00 in the morning and I'm a sleepy girl and I was being punished, for how I looked. And that expectation, we need to be reflecting and saying, is that an expectation of a speech pathologist? Why do I have that expectation? Is that who I am? So reflecting is the number one thing that you need to do, because that's where we can eliminate harm right there, of just knowing, oh, I'm stressed right now. Am I affecting my session? Am I affecting my client? Am I causing harm to my client? That is so important for us to recognize, because a lot of people don't know what stresses them out and they are just moving through their day. I also ask SLPs, what happens to you when you're stressed? What are your coping strategies? They have none. So they're just stressed or angry the entire day, just because something in the beginning of the day stressed them out and they had nowhere to go with that. So we need to work on, what are your stressors and what are your coping strategies? Because you need to be able to get out of that and not affect your sessions.
Growing one's emotional intelligence is one of the hardest things that we can do. And it's not something that is discussed as such. It should be. in grad school, in continuing education opportunities, or just in society as general. But if you want to work on the ability to co-regulate with the patient, you have to start with the dysregulation, but that stems from understanding your emotional intelligence. And we have shunted adults, right, that just weren't mentored in that. Y'all, this is deeper than taking a bubble bath and a glass of wine.
Yes.
Right. This is which I will be the first to admit, I love a good bubble bath and a glass of wine, but like, it's more than that. And for those of you that need to hear it, for me personally, it was the ability to say no. Because I feel like our profession puts pressure on us to say yes to everything, to outperform. It's that to get into graduate school, you have to outperform your colleagues. Then you have to outperform to get the good practicum. Then you have to outperform to get the good job, the higher salary, and it's competition. And we're taught competition. But at the end of the day, our quality of life will suck. But the ability to say, no, this is not the time, this is not the place. And then to, Erin, whenever I think of pivot, I think of you and friends on the couch. But to be able to pivot, I think that's the first step on that journey towards emotional intelligence and growing. But overshare moment, that comes from a lot of introspection. What is the word I'm looking for, Erin? Making myself more gooder. How about that?
Kind of both. And we also need to be comfortable with not knowing. Like, that's a big thing, I think. Going into a session or working with a child and knowing you're not going to have all the answers. You're learning, they're learning. And I do feel like that is ingrained in us as well, of like, you have to have a lesson plan. When you write a lesson plan in grad school, is nothing, the reflection is not, what could you have done? What was your tone like? What was your body language like? How did you approach that child? It's about what stimuli could you have used? What toy could you have used that was different? What paragraph did you choose for that adult to work on comprehension? And so we need to start thinking about our therapeutic use of self and that therapeutic relationship and who we are, and being comfortable with saying, I'm not sure, and being honest and transparent, which is also a pillar of trauma-informed care. It is challenging because you're going to be respond to things in ways that you don't always know that's going to happen, but you need a safe space to feel comfortable talking about it. And you need to give yourself grace and say, this is a learning opportunity for me, because I have kids that I struggle more working with because of the way our differences don't always align to best support each other. And I'm going to work my best to support them, but I'm also in an environment where I can say, maybe I'm not the right fit for this child. Some places you might be the only therapist, but yeah, being comfortable with the unknown is a big thing that we're
along
told we
those
can't
lines, I do want to tell everyone that it is impossible to know everyone's triggers, everyone's stressors. There's too many individual things that we will never know. So the best that we can do is when we do mess up, or not even a mess up, but when we say something that does affect our client, the repair is just as important. I say a lot that as a kid, I never heard an adult apologize to me until I was an adult. And I can't tell you how life-changing it was for some of my high school students when I said, hey, I'm sorry the other day. I think my tone was a little bit tense and you correctly picked that out. And I just wanted to apologize. You were correct. And thank you for patience with me and everything. That's incredibly important. And to make changes moving forward. I think of an example when I was in Douglas. I was there for 6 years total, but I had this poster covering one of the windows so I could have more privacy, and the blinds were closed. And I never even remember that this poster was there, but it was something that was donated to us. And it just said, you miss 100% of the shots you don't take, which is a Wayne Gretzky quote for any of you hockey people, but it's also a Michael Scott, The Office quote, because he quotes that anyway. One of my coworkers walks by that room and the word shot triggered her. It stressed her out. It didn't cause her to cry or anything. It didn't cause her to like hide from that, but it was something that bothered her. So she knocked on my window. She didn't even know it was my room. She's like, "Is this your room?" I was like, "Yeah." And she's like, "I just want to let you know, I walked by this window and the word shot there really bothered me." And in my mind, my first move was defense, right? I want to be like, "Well, you're wrong. It's a funny quote," and move on. But as a trauma-informed provider, I could say, that hurt someone. I didn't even know it was there. I'll take that poster down because for one person, it affected their day. And I'm not saying that everyone is so sensitive for everything, but that was just one change that does not make a difference to me. So I took it down because of what she said. And I think that is one of the harder parts of being a trauma-informed provider, is listening to what they are saying and taking away our own biases and saying, I will do this so that no one else is hurt, or for that specific person, no one also has that experience. That was something that was like a mindset shift for me of, I need to put away that defensive-ness and say, how can I make this person feel more safe? And I don't know what the chances are that she's going to come around that corner again. Her office isn't anywhere near there. But what are the chances that other students who I know have experienced this trauma are also walking by that room and saw that word and just were a little bit fazed by it? That's totally okay. And I can take that down.
So I had an awkward moment this week where as you're talking, I still don't know if I handled this well or I did the best I could in the moment, right? Where the caregiver was bringing in the child that I'm working with, and the child came in dysregulated, headbanging, screaming, crying. The caregiver has their own service animal with them, and the service animal was upset by the patient's behavior and actually started barking because the service animal's still in training, right? Like the other service animal is getting ready to retire. So this is the second service animal. I saw pull into the parking lot another patient that I see on a different day of the week, but they were in for OT sessions. And I know that the noise would set the other patient off. And so it was how do I honor everybody in this moment so that not everybody in the waiting room completely melts down and then everybody's headbanging? Because it was like you see the domino getting ready to fall. Like I am watching the cacophony of events happen. And so I explained to the caregiver and I said, in this moment, I need you to understand that we're working through this with your little one, but the service animal could upset the next child coming in. And she goes, "Oh no, I got this." And she planked the child right out of there and straight back to a therapy room, which wasn't funny, but also the child did look like a 2x4 in the process of all of this. But it was a tiny moment of, I have to honor everybody's needs. And we're also in the lobby and it's impacting every other child in every other therapy room. And for lack of a better phrase, you can't do no harm. So how do you do the least amount of harm in your attempt to do good? And I go back to our code of ethics where it's, engage in
Beneficence.
Yes, that's the word. I teach people to swallow, not to talk. So but it was a hard conversation to be had. And I still don't know if I did it right, because when I get nervous, I jam up my words, but that was hard because I didn't want to cause trauma and there's not always a right answer, guys.
There's not a black and white answer here. As a trauma-informed person, I think you did a great job with that because of your relationship with that family, of being able to talk and you provided transparency, right? You're like, hey, that we're in a clinic right now with people who have big feelings and neurodiversity. There's a lot of stuff going on. And you are acknowledging that the barking is the problem, not that the service dog, which also could be a difficulty. We have children and adults with phobia of dogs. But again, service animals are allowed in protected spaces. So the issue here was the barking, right? Which service animals have to behave where they're at. So the barking is not technically behaving in a way. And your response to the parent of saying, hey, you built that relationship that you can say, here's the problem. How can you help me? How can we figure out this situation together? And that was the right response. I think you did an incredible job there giving transparency, because if you just said, I need you to leave, that is like, why did she just ask me to leave? I think the trust and transparency, the collaboration, mutuality, empowerment, I think you did all of those considerations for both of these clients, and you did the right thing. I think that was a trauma-informed decision through and through.
Because I felt like an awkward turtle, and then we went back on the other.
I have a question for you. I think this is where some people struggle with venturing and diving deep into trauma-informed care, is when you start to look into it, you have to then not necessarily critique, but think back on your therapy prior. And that can be also traumatic, of thinking about harm that you may have caused unknowingly. And that's a stepping into that space, I think, can be challenging for some people, because part of the defensiveness of it can be no, what I'm doing is because I need to convince myself that I'm not causing harm, because I'm not ready to face that. And you know better, you do better. And that's the mindset I always have. But I do find that that's where I get some pushback, is from the fear of, I don't want to believe that what I was doing was impacting
so part of my
clients
self-reflection when I do presentations, I talk about, do you know your stressors, which is the easiest one to conceptualize, right? The last one is, am I causing harm? And what I talk about is, it is better for us to acknowledge that we possibly have caused harm, and it could be like a very minimal thing. We possibly have caused harm, rather than saying, I've never caused harm and I never will, because there's no room for improvement there. So just by this self-reflection of saying, I possibly have, how can I improve, I think is a better mindset to be in, and then move from there. My specific trauma that I talk about happened in February 2018, which is what led me to trauma-informed care. When I go over the course of my 10-year SLP career, I can go over and say, ooh, here's how this situation could have been more trauma-informed. And I think of it as a mindset shift of saying, now I know how to do better in the future, or now I know how to do this for my future clients, rather than saying, oh my gosh, I caused harm, I'm never going to get over this. Trauma-informed care is a mindset shift. I'm meeting people in some of my presentations that are 50 years into their career. And it means so much that they are saying, no one has told me this before, I will do this now.
Yes. The willingness to learn. That's a lifelong learner. If you are the smartest person in the room, get out and get a different room, because you can't grow. And if we can't grow, those that we serve will never meet their optimal state of being, right?
Right. Not even the people who have been in for 50 years, the newbies also, they could take on their personal life experiences. Like I talk about, my brain is on trauma informed 100% of the time. And a lot of people ask me if that's exhausting. And I think to a point it may be, because I'm always thinking about, how can I say this in a way that is not causing harm? But I'm on autopilot now. That's the only way I think about it. And I think I've become a better friend, a better family member in that. I'm a better listener. I think it has improved my life by thinking in this way, and it's become an automatic thing. And it shouldn't be as taxing as I think maybe some people feel that it might be. It should just come naturally when you start thinking in this way, and having those experiences in your career to look back on and say, now that I have this information, here's how I would do that situation again. Here's how I would do that now in the future when that does come up. Or now I can think about each situation, each session differently to be trauma informed. And I think that's the mindset shift that we need to have. Think of it as experiences. Think of it as situations that you can improve upon, I think is the best way to go about it, because otherwise, it's going to be consuming. And I think it's something that we should think about is where have we caused harm? But I wouldn't think of it in that way. I think it's more so a general question to reflect on. Am I causing harm? Have I caused harm? What things am I perpetuating day by day that could possibly cause harm? And it could just be little things. Like when I talk about how can we be trauma informed, it's understanding our dysregulation, understanding the prevalence and impact of trauma, that it is far reaching, right? And altering our language. So just little language shifts that we can use. One thing that I've done is removing violent language. So this terminology was given to me by an SLP that attended one of my sessions. Their child works at a domestic violence shelter. And at that workplace or living place, violent language is not allowed because there is a chance that someone is going to be dysregulated by that. It is supposed to be a safe space. So what I realized at my school, we eliminated violent language without being taught to do so. It was just something that we're like, I don't think we can say that here, or we shouldn't say that here. That does not feel right to say here. You are going to, let's say you're talking to a class of 20 speech kids in front of you. I'm not going to know what things they've experienced in their life. So if I just remove the violent language, which is just shoot me a text, shoot me an email, we just be more direct. Send me a text, send me an email. We've gotten the figurative language, especially in our culture, is very violent. And after you listen to this, you're going to be considering in your day-to-day life, oh my gosh, I didn't realize that we say all these things that are like violent terms, and they've just become very normalized. So I think that's one thing that we can do, because for those of you that work in a VA, that would kind of be inappropriate to say there, right? So why can't we just eliminate that altogether? Why do we need to say those violent terms?
And also the racist, sexist terms that are embedded in our language and we don't even realize it. And that is, for those of us that work in the South, there are phrases that are so ingrained that you don't even know. Calling someone a boy, hey boy, come here, that is so racist. I grew up with my father saying things that I think back now and I refuse to say those, one, because they're racist, but also because I don't want my children to be exposed to that in the home, because you lead by example and you raise your children, out of their mouths come what they hear at home. But those are volitional choices that have to be made to change the semantics.
Right. And it's once you, a lot of people say, I didn't know the history behind that. But the trauma-informed choice is once you know that history,
you
stop saying it. Stop saying it. That's an easy thing that we can do. Changing our language is like a very first step of this. And the violent language is something that you may not recognize that we are using. But I think that also the example that you gave is under the cultural, historical, and gender issues.
Yes.
We have to acknowledge the histories of the people that we are serving, and specifically the reluctance to depend on a provider, right? That's something we say, I don't understand why they don't want to get the diagnosis. They don't want to do this. And we really have to acknowledge our own biases here, which is under the umbrella of trauma-informed care. We really have to pay attention, because the potential is, if you are not being trauma-informed, you may cause harm. You may cause trauma. So by going through each of the pillars, the 6 pillars, and just asking yourself, am I acknowledging cultural, historical, and gender issues? Am I providing safety? Am I providing choice? We will lessen the risk of us causing harm. That is our goal as providers. And by evaluating all of those pillars, we are providing better sessions for our clients. We are creating those relationships. So trauma-informed, as we stated in the beginning, should be a part of each and every class. And not just a course that you can take separately in counseling, which I love that many universities have this class. I've guest presented at some of those classes, and I think they are so essential. But again, they're offered optional, right? So they might say, well, I want to go into neuro. I don't need to do counseling. That's not part of my scope. I'm going to do an optional swallowing class. If that were a section, a day, a couple hours of each class, that could be addressed in such a way that is more effectful than how it's currently being done. And I understand the constraints of the Big Nine and everything. There are recommended mandatory classes, and then there's some of the optional ones, which are an option.
I also, Rachel, loved your post on talking trauma-informed care and neurodiversity affirming care, and how neurodiversity affirming care falls under trauma-informed care, because I think neurodiversity affirming has caught on a little more, but we're missing these bigger pieces as well from that trauma-informed lens. So I just really appreciated that, because I think it's important to understand that as well, that yes, we need to be neurodiversity affirming, but that's a part of that culture and considerations, and there's these bigger factors as well that are really, really important.
And I'm a very visual person, so for me, when I see where trauma informed is in our scope, on my Instagram I have a visual of an umbrella, and the very top of the umbrella is trauma informed care, and then under the umbrella we've got these little raindrops of like words and areas in speech that are trauma informed. Neurodiversity affirming is one of them, and I think a lot of people view neurodiversity affirming as the top, when I view it as under, because the whole purpose of being neurodiversity affirming is that we are not causing harm. We are listening to autistic voices that tell us this specific thing has caused harm to our population. So at the end of the day, at the very top, it is trauma informed. That is the umbrella over all of these little areas that we are trying to prevent causing harm. Even when we talk about feeding, I'm actually presenting at ASHA trauma informed feeding with Dawn Winkleman, which I'm excited about. And I think it's so necessary when you go into each of these very specific things that speech pathologists can do, especially something that you all work with, that it's touching faces, it's feeding people. This is when like people might feel that their lives are in danger. Children might feel that their lives are in danger. The risks are much higher. So we have to make sure that we are trauma informed, especially in these very specific places.
One, I love Dawn. She's delightful and just a ray of sunshine every time you meet her. And two, you are so accurate. Eating is one of the most intimate things that we can do. And breaking bread with another, whether or not it be bread, it could be chocolate pudding. It's we have to reassess the pace with which we're going and meeting our goals. We just need to slow down as a profession, because I feel like if we slow down the rate of our therapies and the pace with which we try to get everything completed, quality across the board would improve. And I think that ties in beautifully, because I look back on how I started out as a therapist, and if I didn't see a patient making quick enough progress, I internalized it as something that I was failing at, as opposed to now it's, are they medically stable? Does their family have the resources they need? But that's all embedded within these pillars. But I hate to be the timekeeper, but I have to be the timekeeper and kind of close us up. But I would love to come.
It's okay. I do need to eat too, because my new medication makes me really nauseous.
Well, then, Rachel, if somebody's also, side note, because I saw a scroll go by and it made me giggle, I love that they call you Ms. A because like that's adorable.
They call me Miss A because my last name is pretty difficult. I had one student and one specific family that was English as a second language. My hair was very red at the time when I started working at the school, and they called me Miss Ginger. The kid was like the ginger. The mom thought it was Miss Ginger. So they all started calling me Miss Ginger and would call the school and say, I need to speak to Miss Ginger. Everyone's like, we don't have that here. They're the one family that calls me that. I thought that was adorable, they all have like a learning disability. Their memory is not great. And my last name is hard. So he came up with a coping strategy to remember my name, and he picked a name, and I think it's the cutest. So we have to make sure we're not taking things personally, because now I have this amazing nickname of Miss Ginger.
I love that. Oh, okay. I was like, I feel less terrible about butchering it.
Please don't. Please don't.
Well, okay. Well, if folks want to learn from you, where can they find you on the land of the Instagram and faces?
Sure. I am at ptsd.slp on Instagram. I also have a website. It's www.ptsdslp.com. And I have all my podcast recordings, so you can find this one on there. And any information you need, I'm on Instagram way too much. So please message me and just ask me questions about trauma-informed care. I love answering.
Nice. Everybody check us out, First Bite Instagram, on Facebook, and First Bite Podcast on Instagram and Facebook. We love it when you get on there and request a speaker or send us an idea for a potential topic, because we want to hear from y'all. We are also coming up on 2 million. We'll have to do something and plan something to celebrate. Thank y'all for being part of our nerd venture. Rachel, thank you so much for coming on today.
Thank you for having me.
Hang on one second, love.
That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I'm your humble but yet sassy host, Michelle Dawson, the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And, as always, remember, feed your mind, feed your soul, be kind, and feed those babies.